cardiovascular disease, a scientific statement given by American College of Cardiology in June 2026. Antiplatelet therapy in primary prevention of MSC, which is major adverse cardiac events. The downfall of routine aspirin. A new statement suggests that prophylactic low-dose aspirin reduces the incidence of MI and stroke but not the death. Because aspirin increases major bleeding risk, its use of primary prevention is limited to individuals at high cardiovascular risk, avoiding routine use in adults more than 70 years of age, but the risk-benefit balance is unfavorable. The current lack of benefit with aspirin for primary prevention may be due to application of other effective preventive strategies like statins. So, the now advisable is use aspirin in age group between 42 to 70 with those only who have high risk of ASCVD, which is calculated by ASCVD calculator, in which more than 20% risk is there. High risk considered as more than 20%. ASCVD risk calculator contains age, gender, LDL, HDL, systolic blood pressure, smoking, and diabetes.
So this is ACCH, ASCVD calculator.
Yes.
You are talking about
Yes.
prevent ASCVD calculator.
AHS.
So high risk कोने केवाय 10 year and 30 year
Yes.
lifetime risk.
Yes, more than 20% lifetime risk. More than 20% 10 years
More
risk.
than 20 છે કે થોડા ઓછા percentage?
No sir, there are 4 criteria: low risk, intermediate risk, low risk, borderline risk, intermediate, and high risk. High risk is more than 20%.
What is low risk?
Less than 5%, sir.
Okay, પછી
Borderline is 5 to 10, intermediate is 10 to 20, more than 20% is high risk based on ASCVD risk.
So this is 10 years.
Yes, sir.
10 years risk
Yes.
of right?
આમ છે ને 70 years વાળું બી ડાઉટફુલ છે. US પ્રિવેન્ટિવ ટાસ્ક ફોર્સ છે ને 60 ગણે છે. આ લોકો 70 ગણે. એટલે 40 to 60 years ની વચ્ચે ઇઝ ઓકે, પણ અબાઉટ 60 નોટ.
હવે આજકાલ જે CKM સિન્ડ્રોમ છે
Yes.
એમાં તમે ACCH નું ASCVD કેલ્ક્યુલેટર કન્સિડર કરશો કે પ્રિવેન્ટ નું કરશો? You are aware of prevent calculator,
Yes.
right? So which is more reliable for CKM syndrome? Prevent માં શું ફાયદા છે? Prevent you can apply from 30 years of age. A. B. Prevent gives you 3 risks. Which are those 3 risks? One is ASCVD, one is CKD, heart failure, and not CKD, overall CVD, ASCVD and heart failure. આમાં 3 risk એ આપે. Right? So એમાં અને ઇન્ડિયન્સ માટે વધારે લાગુ પડે.
Antiplatelet therapy.
Indians માટે 60 years રાખો.
આપણે જે મોટાભાગનું US પ્રિવેન્ટિવ ટાસ્ક ફોર્સની અંદર એ લોકોએ 60 જ ગણેલું છે.
હવે જાપાન માટે 70 રાખો.
For secondary prevention, acute management, choice of antiplatelet in ACS is the recommended strategy of dual antiplatelet therapy with low dose aspirin and potent P2Y12 inhibitor, which is prasugrel or ticagrelor. Clopidogrel should be used with aspirin only in patients with contraindication to more potent agents and those with high bleeding risk in situations where these agents are unavailable or unaffordable. So, recent strategy is like aspirin with prasugrel or ticagrelor. CPG is only used in age more than 70 or where prasugrel or ticagrelor are not available or there is a hypersensitivity to them or high bleeding risk. High bleeding risk is defined as more than one major criteria or more than 2 minor criteria. Major criteria are around 11, which is like stage 5 CKD, chronic liver disease, active malignancy, severe anemia, and major bleeding in last 1 year. Pre-treatment with oral P2Y12.
Last time yes. Popular age.
The popular age study and the trial subgroup study shows that in patients aged more than 70 years of age who have higher risk of ischemia and bleeding, clopidogrel offers less bleeding risk with similar ischemic risk than DABT with prasugrel or ticagrelor.
એટલે ક્લોપિડોગ્રેલનો એ મૃત્યુદંડ ભાગી ગયો.
હા, more than 70
More than
years હોય ને
તો આ
રાજુ દે ટીકાકરેલ નહીં વાપરતા.
હા, એટલે જ કહું છું કે હવે 70 ની ઉપર વાપરવું નહીં.
So basically clopidogrel is weaker antiplatelet than prasugrel.
પેલું રેઝિસ્ટન્ટ બી જોવા મળે છે ને.
genetic polymorphism, right?
Pre-treatment with oral P2Y12 inhibitors in case of acute coronary syndrome. Pre-treatment with oral P2Y12 inhibitor may be considered in ASCVD and MI, and in non-ASCVD and MI, it should be given when the angiography will be delayed by more than 24 hours. Although in current era, this patient population is relatively small. They want to say that in non-ASCVD and MI, if angiography is delayed for more than 24 hours, then only you need to give loading dose. Otherwise, you can directly proceed with PCI. Intravenous antiplatelet drugs during PCI. Intravenous antiplatelet drug we have in GPI, GP2-3B inhibitors, tirofiban and epinephrine and canalorol, which is P2Y12 inhibitor. They are very potent, but they have high risk of bleeding is there. But only used there for bailout for thrombotic complication or no reflow after PCI. Otherwise, they are not used commonly because high risk of bleeding, especially when femoral access is taken. Duration of DABT after PCI. This is a major change or major recommendation. Is the default duration for DABT?
Still, this major recommendation is not done by most of the cardiologists. Even if I advise to my patient, they go to the cardiologist. અને નહીં કે તમે તો આ બધે કોમ્બિનેશન ચાલુ જ રાખો. Even after 1 year. એટલે કાર્ડિયોલોજિસ્ટને જ ખબર નથી હોતી.
The default duration for DABT.
જરૂરી છે બરાબર. મોર દેન 1 year તો મેક્સિમમ કદાચ 6 મહિના આવે તો 1 year બી બહુ
અને એ ઇવન આફ્ટર 2 years આવે ને એટલે પેશન્ટ રૂટીન ફોલોઅપમાં બીજા કોઈ કારણસર એટલે કે સાહેબ આ દવાનું શું કરું? The moment if I advise that you have to stop this drug, they go to their cardiologist and the cardiologist કે નહીં તારે ચાલુ રાખજો.
મોટા ભાગના કેવું કે 6 મહિના પછી તમારે આવું જ આવે.
આવું જ નહીં. ચાલો.
The default duration for DABT for 12 months has been increasingly questioned in the era of newer generation drug-eluting stents, particularly in patients at HPR. Newer generation drug-eluting stents are having risk of restenosis between 0.1 to 0.5% in 1 year and less than 0.1% after 5 years. So 12 months duration for DABT is not advisable now. Several trials evaluated that DABT followed by P2Y12 inhibitor monotherapy is advisable. High-risk patients who have completed 3 months of uneventful DABT with ticagrelor plus aspirin were randomized and continue DABT to switch to ticagrelor monotherapy. The discontinuation of aspirin significantly reduced spark type 2, 3 or 5 bleeding without increasing death, MI or stroke. Similar findings were observed with TICO study and target first study. The recommended strategy is 1 to 3 months of DABT followed by ticagrelor or prazolam monotherapy to reduce major bleeding with comparable incident outcome versus 12 months of DABT. The
HPR એટલે શું?
high bleeding risk, sir. High bleeding risk, yes. Major and minor criteria are there. And bar bleeding is like type 1 is no bleed, type 0 is bar classification is type 0 to type 5, type 0 is no bleed, type 1 is minor bleed, type 2 is overt bleed, type 3 is major bleed where the hemoglobin falls more than 3 gram per deciliter, type 4 is bleeding after CVG, and type 5 is fatal bleed. So recommended strategy is to give DABT for 1 to 3 months and then switch to ticagrelor or prazolam for 1 year. And aspirin should be used only where the age is more than 70 or high bleeding risk is there. Antiplatelet therapy post CABG. Post CABG, the TAC.
Now the question is that ticagrelor is continuous for 1 year.
Yes.
After 1 year you have to stop every
No, after 1 year, we have to switch to clopidogrel for life.
Clopidogrel.
Yes. Antiplatelet therapy post CABG. The TACS taxi study suggests that DABT did not reduce the risk of death, MI, stroke or repeat vascularization compared with aspirin alone in 1 year. Post CABG only aspirin is advisable. However, DABT reduces the graft failure, but there is no reduction in the MI or death with increasing the risk of bleeding. So aspirin only is advisable till 1 year. Long-term antithrombotic therapy beyond 1 year after acute coronary event for a revascularization. The choice of antithrombotic therapy beyond 1 year after an ACS or coronary revascularization requires careful balancing of residual ischemic risk against bleeding risk. Aspirin monotherapy. Aspirin monotherapy has served the foundation of secondary prevention for decades, but now it is not preferred. If aspirin used to be given, it should be given in the superior tolerability of low dose aspirin supporting preferential use for long term therapy. As sir asked before presentation to what to use 85 or 325. Low dose aspirin is preferred. In India we have 75 milligram of aspirin. Aspirin versus prolonged DAPT. The prolonged DAPT trial showed that continuation of DAPT for 30 months after death DES implantation reduces ST and spontaneous MI compared with aspirin alone, but significantly increased moderate or severe bleeding and was associated with increased non-cardiovascular death. Hence, prolonged DAPT is not advisable. It should be given only in carefully selected patients with high ischemic risk and acceptable bleeding risk. Aspirin versus P2Y12 inhibitor monotherapy. The emerging data suggests that clopidogrel monotherapy may offer greater ischemic protection with similar or lower bleeding risk compared to aspirin. Therefore, secondary CAD prevention will continue with clopidogrel after 10 years. And SMART Choice 3 trial and 10-year follow-up of the host exam trial both suggest that clopidogrel monotherapy is preferred over aspirin. Aspirin versus oral anticoagulation alone in patient without any indication of oral anticoagulation. Post ACS after 1 year, even if there is no other indication of oral anticoagulation like atrial fibrillation or previous history of venous thromboembolism, the VARIS trial, warfarin and aspirin or both after MI, and VARIS 2 trial suggests that warfarin monotherapy was at least as effective as aspirin in reducing ischemic event after MI, but with higher bleeding risk and management complexity, warfarin is not advisable. However, newer anticoagulant drugs like rivaroxaban, 2.5 mg twice daily to low dose aspirin significantly reduce MSE and total mortality rate in patients with stable CAD or coronary artery disease and peripheral artery disease despite a higher risk of major non-fatal bleeding. Rivaroxaban 5 mg twice daily alone did not significantly reduce MSE versus aspirin alone. So, anticoagulation post ACS after 1 year without any indication is not advisable. However, there are studies with rivaroxaban low dose 2.5 mg twice daily with aspirin can be given, but there is risk of non-fatal bleeding. Antiplatelet therapy in special population, peripheral artery disease. In acute management, after endovascular intervention and antiplatelet therapy is often intensified to prevent thrombotic complication. Post stenting, DAPT with aspirin plus P2Y12 inhibitor is typically considered for first 1 to 6 months, and short course DAPT 1 month followed by antiplatelet monotherapy may be sufficient undergoing surgical bypass, especially with prosthetic graft. They are suggesting that if surgical bypass with graft is done, then 1 month DAPT is enough. While in percutaneous intervention with stenting, it is advisable to consider 1 to 6 months of DAPT duration. After 6 months, the prolonged triple therapy, anticoagulation plus DAPT is not recommended due to high bleeding risk. Both aspirin and clopidogrel are reasonable choice for antiplatelet therapy in this patient population, although the Capri trial suggests that clopidogrel may be a better choice. Chronic management of peripheral artery disease. Patients with symptomatic peripheral artery disease should be on long-term single antiplatelet therapy to reduce the risk of